ja järgmisena lähme oma mõtetega Põhjamaadesse ja ma tutvustan kahte järgmist esinejat. Nemad on Rootsist. Meil on külas siin Niclas Forsling, kes on Västerbotteni piirkonna maaelu meditsiinikeskuse projektijuht ja tema kolleeg on Sofia Hemmeti ülikooli professor Christine Gustafsson. Ja nemad siis räägivad sellest, et mismoodi kauglahendustega neid tervishoiu ja sotsiaalteenuseid päriselt inimesteni maapiirkondades viia, mis ongi tegelikult sama küsimus, mida Hanna adresseeris, et kuidas inimestel on päriselt mõtet ja tarvidust kasutada seda kõike, mis on olemas. Ja kuna nüüd järgmine ettekanne toimub inglise keeles ja sellele järgnev ettekanne Soomest on ka inglise keeles, siis need, kes eelistaksid kuulata tõlget. Meil on olemas sünkroontõlge, kellel veel tõlkeaparaati ei ole, siis sealt registreerimisletist saate endale ja küsimusi võite Slidos esitada nii eesti kui inglise keeles. Mina saan mõlemast keelest täitsa adekvaatselt aru ja nüüd ma lähengi inglise keele peale üle. Next up is Niclas Forsling, project manager at the Center of Rural Medicine in region Västerbotten in Sweden, and also Professor Christine Gustafsson from Sofia Hemmet University, who will share their insights about how they are bundling together technologies and people's needs. And there are some fun facts about them as well. Christine is a keen gardening enthusiast who has just started gardening and has grown her own asparagus this year and was very proud of that. So that's a good inspiration. I'm a keen gardener for many years. I'm not telling the number because it's since I was born, but I have never grown asparagus. So thank you for inspiration. And your inspiration is even more challenging. He is a huge fan of ice hockey, but as this is quite, let's say, injury-prone area, has resulted with many bone fractures. With Niclas, he has delegated this game to kids and is now coaching. So besides doing everything professionally, they are also pretty cool people in their own lives. So please, the floor is yours. Please share experiences.
Thank you very much. Yes, yeah, it was good actually to delegate it to my kids. It was my wife that told me that stop playing ice hockey after my, I think it was fourth bone fracture. So I had to stop. Me and Christine has worked together. She's a professor at the University of Mälardalen, Sofia Hemmet University, connected to Mälardalen University. I'm working at the Center for Rural Medicine, as was said. It's a R&D center. We are a national center for rural health in Sweden. And I'm going to speak a little bit about work that has been done for over 7 years period. And we have done a lot of work with people in this room, actually. So we have worked with Sarama at Tallinn. We have Elva over here. We have Palme was here also. So we have met many of you before, and that's good. What the first project was called was Healthcare and Care Through Distance Spanning Solutions. And this is a kind of knowledge hub you can use if you want to go back and see what we are speaking about. And it's very well organized. And the first task that we got to do was to look through existing solutions in the Nordics. This is basically a publication after mapping out several hundred solutions that are no pilots. It's actually solutions that are there to serve the people that are having technology in the background. Of those several hundreds, we took 24 practical examples. It can serve for inspiration for you. You may find something that you find is interesting for you to use. And what are we speaking about here? It could be self-monitoring, that you conduct self-monitoring. Look through this stands over here. A lot of self-monitoring equipment are existing there. So you could actually do self-monitoring as a COPD patient, for instance, that you self-monitor so you know how well you are today to be able to go out in the forest to maybe pick berries or whatever you want to do. And this is, of course, there to actually provide some kind of security and you know, possibility to work as a normal, or do whatever you want as a person. It was also on the stands over here, GPS trackers, which is connected to safety alarms. A fun fact of this is that we in Sweden don't use that much these GPS trackers, so you should definitely go for GPS trackers directly if you implement this solution. A selling point for this is that maybe 15 to 20% of the users are delaying their illness progression by using safety alarms with GPS trackers, because they can move outside their own homes and live a normal life. And this saves approximately, in the research that we looked at, approximately 12,000 euros per year a user. So it's a lot of savings that can be done for the society. But in this context, we should say that the clear responsibility for the citizens are on the municipalities. So they have to take care of the citizens and have 24/7 responsibility for them in the Nordics. So it could be a little bit different here. We looked at the second part that they asked us to look at in this project was how to implement solutions. And many people are starting to think about implementation and how to do that. And we looked through the different guides and we found out that there are existing guides. Don't develop your own guides. Look at what is existing and what you can use for in your own municipality. And we found out what fits the Nordic context very well is roadmap for service innovation, applied in Norway, developed by Norwegian Association for Municipalities, and has been tested by us in several projects, and it works well. It's a guide that are focusing very much on the two first steps here, anchoring in insight. Don't think about technology. Think about what you want to achieve. Discuss that with the persons involved and put a lot of time and effort into this. Then you design a service model and then you pilot for wider implementation. So that was the background that we had. We did a lot of other works here that you could look into that could be interesting, related to CO2 emissions, how citizens are feeling using these solutions. What are the professionals' view of this? And it's very much positive all the way around, from whatever angle that you see. But what we're having in the Nordic countries is that we do this from a rural perspective. It's a lot of rural areas also here in Estonia. And we need collaboration on another level. So we started to think about integrated healthcare and care through distance planning solutions. And integration in our case is then integrating the social care services that are on municipal level and the healthcare services that are on a regional level in the case of Sweden. And the integration needs some kind of backbone to keep it together. So we asked Norwegian Center for e-health Research to look into theoretical framework. And the basic framework to collaborate and get collaboration going over time is that you need a forum for communication and knowledge sharing. You need to identify that you have some shared goals and potentially over time develop common goals in the collaboration. Then the different entities will start collaborating and you will build trust over time. So these are the two main takeaways that I would give to you. Don't develop your own implementation guides. There are guides that are working. We have those ones that we have, Roadmap for Service Innovation, translated into English also, but also some other Nordic countries, languages that you may know. So try to look into that. And when it comes to collaboration between entities, you need to think of the communication, the space for communication and knowledge sharing, and how to identify the shared and develop common goals, because it's all about trust. As you can see on this map, we have worked with a lot of different regions in the Nordics. And those of you that have good eyes can see that we've worked with Tallinn, Saaremaa. We've also worked with Elva municipality. So we have collaborations also tested this in the Nordic countries. The ones that are in pink here are related to implementation. The ones that are in blue is more collaboration between entities. So we know this works, but we have a challenge to see that it stays over time. And that's why we have Christine Gustafsson here.
Thank you for that, Niclas. And every day you learn, and today I've learned terre hommikust. I think it's correct. It means good morning. Yeah. But yeah. Yeah. Yes, and I will give you some real-world examples underlining what Niclas have already said. So this is your thank you slide. And this is the address for the web pages where you can find all the documentation from the IHAC and VUPD project. And there are a lot of reports there. So now I will explore leaders' experiences of successful implementation of health and welfare technology, or HWT as we use it, in sparsely populated areas. This work is a part of a broader Nordic initiative titled It's All About People, which focus on how digital and distance spanning solutions impact health and social care services, especially in terms of workforce and organizations. Our presentation is based on 2 studies. The first explores what leaders themselves identify as key factors for successful implementation. And the second study applies a model, the Lippitt-Noster model, for managing complex change to these experiences, helping us understand what factors support or hinder success in different local contexts. The first study I conducted with my colleague, Dr. Petra Danapfel, and she is a researcher in implementation science, and she's now working in the west of Sweden, in Gothenburg, as a manager of development. And these are the 2 studies, and again, both of them are to be found at the IHAC website. The first one is a published scientific article that's open access, so it's available for all. And the second one is a report. But before I start to talk about the studies, I would like to have a shared point of departure with you. In the Nordic areas, we talk about health and welfare technology. Which often is abbreviated as HWT, and we refer to a broad and evolving landscape of digital tools and systems designed to support health care and daily living. This includes everything from e-health and telemedicine to m-health apps, wearables, devices, and robots. Welfare technology, digital assistive tools, and smart home systems are also part of this ecosystem. Increasingly, we see the integration of clinical decision systems, cognitive support technologies, and care alarms with sensors to promote both safety and independence. These technologies could serve to help us with different goals. And they are meant to promote safety and independence, which are 2 of the main goals of why we should use this kind of technology. On an individual level, they can enhance safety, promote autonomy, and support health and participation. At the system level, they can improve efficiency, reduce cost, and make service more accessible, particularly important in remote areas. HWT can also have positive impact on sustainability and staff's work environment by supporting more flexible and responsive models of care. So HWT is not just about the technology, it's about enabling better health, better care, and better or improved quality of life for both the users, the older people, the people with disabilities, and also the care providers. So what we know about implementation of HWT? Well, implementation efforts often fails. That's what we have learned in the research, not because of the technology itself, but due to a lack of readiness. We know from research that up to 70% of large-scale implementations fail. Readiness is not just about tools or plans, but about preparing people, fostering commitment, leadership, and capacity across the organizations. So what do we know about readiness? Well, if both psychological and behavioral, it's about whether staff are motivated, equipped, and able to implement change. Readiness involves individual and collective dimension and reflects how primed an organization is for action. So we have analyzed 12 semi-structured interviews, and we used an inductive thematic analysis with a reflective approach, but we will not dig deeper into the methodology today. But the result of the first study, the leaders' experiences of successful implementation. The findings includes success factor identifying during the implementation of HWT in sparsely populated Nordic regions. The results are structured around 5 interconnected and overarching themes. The first one is about positive attitude towards and an understanding of the ongoing digital transformation we all are into in our private life, but also as professionals. The second one is that it's needed a consensus, agreement on the change, the challenge of changing the way to deliver care with support of this technology. So we can't keep on deliver or provide care in the old way and also use the digital tools for this. We have to change and maybe leave the old way. The third factor is about leadership and organizational readiness for change. We need strong leaders to lead this change we are doing when we are implementing the technology. And we also need to prepare the organization. It's not just about to plug in the technology. We need to prepare the whole organization with IT support, with funding for the new technology, maybe build a new infrastructure as well. The fourth one is about effective feedback mechanism. We need to follow development, put up some part goals and overarching goals, and follow how we are succeeding in this work. And the fifth one is about trust and engagement in the learning process. We need to understand that we might know where we end up in this work. Sometimes it needs to restart and do it better, and maybe to restart even a third time to do it better this time. So we need to have an acceptance regarding this. And how can implementation science and theory support this? Well, implementation science provides structured framework, as Niclas gave you some example of, and tools to support the successful adoption and integration of innovations like health and welfare technology. It could help us by identifying barriers and facilitators at multiple levels, in the individual level, organizations and systems. It could guide us in this design of tailored strategies to support change, because this is about change in our way to deliver and provide care. It could be like using models, for example, a model called the CFIR, or consolidated framework for implementation research, or Wiener's theory of organizational readiness. When we analyzed this data, we saw very much of this theory that the organization need to be mature and ready for this change. And it could also ensure continuous evaluation through feedback loops and outcome tracking. And finally, it could also promote sustainability by embedding learning and adoption in the process. So, organizational readiness is about shared beliefs. Do team members believe they can carry out the change? This includes confidence, known as change efficiency, and commitment. Readiness is always contextual and dynamic, not a one-size-fits-all condition. In the second study, we applied the Lippitt-Noster model, This model outlines 6 essential elements for successful change. It's about that you need a vision, you need consensus, you need skills, incentives, resources, and an action plan. So if you can see in this illustration, if one is missing, it can lead to problems like confusion, resistance, or even sabotage. So you have to get everyone that should be on board. In this deductive study, we found evidence that all the interviews contained elements consistent with the Lippitt-Noster model. While the concepts may not have been expressed using the model's exact terminology, they could clearly be interpreted and identified with the leader's descriptions. So again, this is where you could find this article and also the report. And thank you for your attention, and you can read more about this on the website. And I hope, and we hope, that these insights inspire more informed and inclusive implementation strategies, especially in rural and underserved areas. And later today, we will have a workshop grounded in the Lippitt-Noster model, focusing on its application in managing complex organizational change. And I think implementing health and welfare technology and social services in municipal services is actually a complex change we're working with.
So, we have a workshop after lunch. Just to give one example here, this sounds very complex. We're going to work on the Lippitt-Noster model, which is then about, the vision, the consensus, the skills, and we all know these factors, but how do they actually play together? So we're going to give some practical examples for you, and you're going to sit down with us and see how you could actually apply this also in your context when going back home. So thank you very much.
Please stay in the stage because we still have some Q&A session for you. Teil on nüüd võimalik küsimusi esitada Slidos ja ka kätt tõstes. So you can ask questions both from the audience, raising your hands. We will have the handheld mics going around magically in the room, or you could also use a Slido asking the question. And we have already 5 questions here. Yeah. So I'll start with quite randomly, to be honest. How to increase the readiness to end users, e.g. also caregivers. Please give some first insights on the caregivers and the end users.
Yeah, I mean, what we are saying is that everyone involved in the caregiving process needs to be part of this process, including the user itself. That's how you design a viable model and a sustainable model for the user. So you need, if you think about this implementation guide that I spoke about, insight and anchoring and insight, just go back to that over and over again. And you need the right people around the table and involve all in the design. Otherwise you will fail. That's 100% sure. Many people go directly to technology and think that we have a technical solution here. You may be inspired from these tables, but as we are saying, this is not about technology. It's maybe 90% is about human relations and organization of the care. 10% is supporting that care with technology. But technology is not it. It's the relation between the people.
Yeah, there's a question for Christine. Is the sequence of these 5 key factors important?
No.
So it's like making the pancakes. You have all the ingredients, mix it together, right?
You need all the ingredients, and maybe you need to start with one of these success factors, but all of them is needed. And we could also look into the Lippitt-Noster model. All of the critical elements are needed. But of course, you might not from the start have them in place, so you need to work with them continuously.
Yeah, and nothing comes overnight. I mean, for those of you that like football, I don't like football, I like ice hockey, but those of you that had a game that you watched most likely on Saturday, and you all know that Paris have worked 50 years with a lot of resources and added a lot of skills to their team. Took 15 years to win Champions League because they didn't have the consensus. All of a sudden, they brought the players in that were not stars, and they got the consensus towards the vision. So everything is about planning carefully to achieve the goal.
And work with the whole team, and also include the end users as the older people, the people with disability, the families, the relatives, but of course also the professional caregivers, the IT support, the infrastructure, the funding for it. So it's a complex change we are talking about.
And there is a question, especially how to support these people who are not digitally so fluent or comfortable using all these digital solutions, how to really start using them, how to be onboarded.
Yeah, I mean, this is also a question if they should use it. We should always know that everything is about human relations, and it should be used by the people that are ready to use it, that have the ability to use it. I looked at the GPS trackers over here, and basically the GPS tracker is a watch that you have on the wrist, and then you have a button on it. If you want to see light when you walk up at night to be able to find to the bathroom, you press the button to get light. The difference is not that much. It's behind that the difference is. So technology is one thing, but if you feel insecure with technology, you need to build trust over time.
I also would like to add, it's also about the incentives for all the involved users. What's in it for me? Why should I use the GPS tracker? What's the meaning of it? And maybe it's not a one-size-fits-all solution, even though when we talk about the technology. So we must really figure out what's in it for the stakeholders and the individual users. And I think a strong way to work with this is to work with storytelling, people who are really supported by the technology, and why and how they are supported with this technology. Is for maybe the old person living in the private home, it's about to feel safe and secure when you age in place. It could also be a support to stay independent, which is very important to people when we look into the research. To stay independent in the Nordic area and also the Northern Europe is a very good incentives to work with to introduce technology, because it could support you to prolonged independent life when you're aging in place.
And that's the story you tell.
Yeah.
Yeah, could I just add one thing? I see Heidi is sitting over here, so I can't remember if it's your story that I'm stealing now, but I think it was a Finnish municipality, Finnish well-being service county that told me the story about GPS trackers. That people with dementia, of course, it's very good for them because many of them are runners or they are walkers. They walk out without telling anyone, and you can't find them. Research are telling approximately 568 hours per user are saved in rescue activities. The interesting part is, however, that they found out that they make a new map in their head. So by having GPS trackers allowing them to go out, they draw a new map in their head so they can find their way back. Isn't that amazing? People with dementia draw a new map and they can now navigate.
There is also quite an intriguing question. Have you calculated, or how do you calculate the cost of doing nothing in social care?
Well,
I think the question have a foundational meaning in that we should calculate it in money. But maybe we could calculate it in other aspects, maybe quality of life, satisfaction, existential health, if you are having the possibility to stay at home as long as you can. So it's hard to calculate it, but there are some models that are used in Sweden, for example, by the Swedish Association for Local Authorities. They have created some kind of calculators how could you look into your municipalities by different factors, and what could the benefits be when you calculate it in financial terms?
Calculation is for the politicians to sell the idea to them. I mean, we are speaking about human relations here, so shouldn't speak about technology. We should see how can we increase the human relations, because technology helps create time to sit down with the person that you serve and speak to them. I mean, the biggest fear, as you are saying many times, is for people that are getting old and may get to special housing or need a special housing, is that they lose contacts with their friends. They feel more lonely being at a special housing where they are surrounded by many people, but they are not surrounded by the loved ones necessarily.
Whereas a question regarding readiness, you could both address it, and it is, over time, what changes have you noticed in organizations or target clients' readiness levels? How long does it take? So how fast these changes happen? And what has been the impact of these changes in the most major way?
I mean, then I take an example of South Karela Wellbeing Service County, which was the first basically service county in Finland, Hämeenlinna area, and they started 15 years ago, and they are saying that they started 10 years too late. So you can never start too early to think about how to involve all stakeholders in the planning process of how to become old. So my advice is to take these models and use them, even though that you are not using technology. It's about human relations again.
Yeah. Again, you need to look at the incentives. Why are we planning to implement this support system? And then again, we must all remember that technology doesn't have a meaning by itself. It's just tools in the toolbox to serve the people who need support in their everyday life and maybe have other needs regarding their health and so on. And we used to say, when working with your health, it's never too early and never too late. So I would say the same here. But it's hard to answer the question how long time it takes, because there are so many factors in this complex change. If you don't have the infrastructure, you need to build on that. You need financing that, you need to work with the infrastructure, and you also need to look at the business models, how this is financed, and also regarding that we are living in a very rapid technology world today. When we buy our technology, it's already old. So the question is, should we buy the technology or should they be leasing solutions? So there are so many factors. So it's very hard to answer that question with a simple question. It depends on what.
Yeah, I steal yours now. We got it from Elva municipality, because I looked at your slides. They wanted to be as common to use technology as you have a walker. You know, walker.
Wheel walker.
Or hearing aid. Hearing aid is actually technology, but you don't think of it as technology. But technology is there to be used, but it's not that is the key. I think we're done. I'm seeing people are coming up.
No, we have many questions here.
Okay, we have.
Yeah, I'm sort of halfway through.
Okay.
I'll make my kind of moderator's choice of which questions to prioritize, but there is a question of, is there like the solution which you have found so far the most successful, which is the most, I don't know, easy to implement or impactful, or is it uptake is something going really well? Something you can share as a story, like the biggest success story out of your portfolio.
I mean, if we take a Swedish context, we are using safety alarms. I mean, I know that many of you offer safety alarms to families. You use the GPS trackers as safety alarms. We have analog safety alarms that works in the house. That's a success, of course. My mother has it. She calls people when she's fallen, and then they come and help her. We have organized it through the municipality. But safety alarms that works also outside the house are making so much savings. So safety alarms first. I think when it comes to a healthcare perspective, we think that medicine robots that are actually providing you with the medicine, the correct doses that are in a cup feed it to you at the time when you should have it is also a very good solution to implement. You save a lot of money on that, but you save also the challenge of making sure that they take the right medicine, because most of us that are taking medicine are taking the wrong doses now and then, and that hurts more than taking the medicine.
There are also some comments saying that I totally agree that it is not just having the technology ready, but it is to have the understanding of importance and implement it like an ecosystem, but everybody needs to be on board. So it was also like the key message. You need trust, you need communication, you need networks. Networks takes time to build. How did you make these small rural municipalities collaborate from one end of country to the other?
Yeah, I mean, our center is based in a rural municipality. We have 6,000 people living there, 0.7 person per square kilometer. I'm sure that the people from the rural municipalities here would agree. True collaboration exists in rural municipalities, and it's the collaboration between the social services, healthcare services, family, friends, and the users. So true collaboration, if you want to study how collaboration should look like, you have to study almost rural municipalities. They are in the forefront. The more urban you become, the less collaborative we are, and the more siloed we get, unfortunately.
Yeah, and we have also learned that what works in rural areas also works in urban areas. So we have a rural first attempt in this work.
But that's common. I mean, you're in the forefront of digital development in Estonia as such. Any digital new solution that are implemented are done through a minimal viable product. You want it to have as few features as possible, and you want it to be implemented in a context that have low level of complexity. That's why you should test everything in rural areas. That's how you get innovation going. That's how you get collaboration. That's how you actually get development in a field that actually turned out through COVID to demonstrate that you are the quickest to make a turnaround and make it work.
Thank you. Is there a question from the audience here? Somebody wanted to ask or raise a hand? Just checking. No. So thank you very much, Christine and Niclas, for coming, for sharing. It was a huge inspiration. You have scientific background, you have all the links. We can use them, and rural first is something which is very often counterintuitive regarding technology. Everybody thinks that things start with cities. No, it starts from rural areas, from villages. Thank you. There is a small thank you gift. It is Chocolala. It's Estonian handmade chocolate. Very nice. Thank you very much.
Thank you.